reporting back, since I don't have the whole list of Google Docs, Anne Marie, would you be willing to share your screen of their notes?
Oh yeah, I should get them all open. Yes. Yes, I will. I'm gonna go open them up here now.
Okay. I didn't anticipate such good turnout, so I only made 10.
I know, it's amazing. It's great.
Yeah. I'm just gonna step away for 1 minute. I'll be right back.
Hey, Erin, I think I went into the wrong break room. I don't know. I think it was 14. The 10 wasn't the one, but I think it was 14. Got kicked out. I don't know.
Okay, I'll try to send you to 14. That's okay.
Okay, yeah, thank you.
I wouldn't remember the number either. Okay, let's try 14.
Okay, thanks.
Sure. Did the pop-up come?
No. Let's see. No, it didn't. Yeah, I'm not seeing anything. Let's see.
I have you in 14, but let me.
Okay.
I'm going to move you to the wrong room first. Hold on.
Okay.
And I'm going to move you back to the one you're asking for. Hold on.
Okay. All right. Thank you.
So move to 14. Did it pop up now?
Let's see. No, it's weird. It keeps saying connecting to audio with something else on the bottom, and then one person's name, and then you're on there. But there's, yeah, that's weird. I don't know why it's doing that. Huh.
For me, it has you in there, like that you were invited to it, but not that you joined it.
Okay. Okay, now I'm seeing 3 different people, but those names weren't the familiar ones. I can just be placed in there if that's okay.
That's fine. Yeah.
Okay. All right. Sounds good.
Okay.
Okay. Thank you.
Sure. If anyone else is not in a room would like to join one, just let us know and we can help you get into it. Otherwise, that's fine too. should we go ahead and close the rooms? It gives 60 seconds, right?
Oh, right.
Okay.
Okay. Closing.
Thanks for joining. It takes about 20 more seconds for all the rooms to close and people to come back to this main one, and then we'll start having some discussion and sharing what y'all talked about in your small groups. Okay. Well, thank you so much for staying in the groups and talking about some of the interventions. So we have all the Google Docs, so we can look at your responses, but we thought it might be nice to have a couple of groups volunteer to share their responses, and then someone from our team can show your Google Doc and you can talk through it. Is there a group who'd like to share their responses? Michelle Miraman? Okay, so which group were you in, Michelle? Do you remember the number?
9.
9. So Anne Marie, can you share 9's document? Thank you. All right. So go ahead and tell us about what you guys said.
So for the most liked, we all came to the conclusion that medically assisted treatment has become a very good intervention, because it helps people to, not go out there and there's still people that do still, use if they're not on the right dosage and stuff like that. But then there's some people that are really successful in it and are able to succeed in it and not having to go steal or go out and use and do all that stuff. So we just figured that was a really good intervention. And then the most feasible interventions we discussed and came out with education and training, being able to educate and train people in the fact of medically assisted treatment and the harm reduction of being able to help people. And then the disliked one was number 10, the government and organizational policies. And then another intervention that one of the ladies really liked how she put it is the cultural teaching, being able that could be used as an intervention as well. Is cultural teaching. And then for question, I think it was 5, what barriers might people impede with stigma? And it was the medically assisted treatment that we liked the most. And then strategies to overcoming was using non-stigmatizing language.
Can you say more about why you dislike the government and organizational policies? What were some of the things that everyone mentioned?
Can you go down to 10? That's all I had wrote down from it. I guess because of the fact it was number 10, the possible intervention of requiring all eligible prescribers to obtain buprenorphine waiver is kind of what we had discussed that we didn't like so much. We didn't really go over much of why we didn't like it, but that's the one we chose.
Our
Thank
group
you.
had the same thing, and what we discussed was basically it's not exactly feasible to have all prescribers complete the waiver, especially if they're not even treating patients that would benefit from it.
Great point. Would anyone else like to respond if they didn't like number 10, or maybe someone did like number 10?
Our group also didn't like that particular one. And for the same reason, it just doesn't really make sense if a provider's not working with that population for them to do the extra documentation. There's enough licensure that providers already are having to keep up on. And if they don't even want to work with that population, kind of what's the point? Because then patients that go in will just face stigmatization with that provider in the first place.
Great points. Is there another group that would like to share all of their responses? Thank you so much, Michelle, in group 9. That was very helpful.
I was going to say for group 18 for number 10, we had spoke of if you require providers to do it, if you have a provider that is anti MAT, it may pose more of a problem with the patients than good. It may do more harm.
Yeah, that's a great point. I saw someone put their hand up for maybe wanting to share their group. I don't know who it was.
I think for us, group number 4. Do you
Okay,
want me
group
to share
4.
the screen?
Anne
see.
Marie, can you share group 4, you think?
Okay, I think you can see it, right?
This looks like group 1, yes.
Okay, so so for us, yeah, I was just making sure that that's our document. Okay, so for us, I think we went through the questions kind of like as just one topic. We didn't really in an organized way as far as like 1 through 6, but one of the main highlights that we came up with is really having that contact-based intervention in practice for providers. And also one other intervention that really came out a lot was the tool of motivational interviewing and how not only providers can use it, but even like give access to community leaders such as, you know, city councilors, county commissioners, different community key leaders that can use motivational interviewing as a practice when coming in contact with the community. We talk about how more of a community collaboration. They also shared what the peer opioid project is and how actually one tool that can help reduce stigma is having more resources for peer support workers that actually have lived experiences and that community members who are struggling with SUD can come in contact with and feel more comfortable about having help from peers because they can relate as far as lived experiences. We also talked about the disparities in jail population and how that relates to the stigma when it comes to white versus non-white people in our community. That is related to class, money, and of course, ethnicity. If any from the group would like to add anything that I might be missing.
You did great, Marina. Marina, this is Dennis Lopez. And yeah, we did have a real good detailed discussion about everything. And I did also discuss them not only in my mental health resources care in New Mexico, but I'm also a county commissioner. And we just implemented a MAT program in our detention center where we're fully staffed and we're just waiting to get the process going. If I'm not mistaken, I think we're one of just a handful of pilot programs throughout the state of New Mexico. So yeah, we did address a lot of issues in reference to the stigma and how it's changed quite a bit in the positive over the years here in Roosevelt County, Curry County, the eastern part of New Mexico. And it's been solely because of education, outreach, and just getting with people that are in the federal, state, local levels just to get them educated and try to get that stereotypes and myths and discrimination and everything out of their heads and to open their eyes and not have that tunnel vision as to what we have to go through in behavioral health services on a day-to-day basis. So we did have a really good conversation in our group. Thank you guys.
That's wonderful to hear about Roosevelt County. And I like that, it sounds like you've already been doing interventions. You've been doing education on the front end to address the stigma so that the program can work, which is amazing. Wonderful. Would another group like to share?
Yes, can you do group 1? I don't know if the next group wrote on top of ours or I'm not sure, but I wrote it down on a piece of paper.
Okay, you can also share it verbally if we don't have the Google Doc.
Okay, so on the first one, we chose the contact base. We felt like it was more personal relationships and the clients were more likely to open up, were able to contact more due to the personal experience rather than the therapeutic base, where a lot of therapies are just strictly based on books and the research, where contact is more relations and more peer-to-peer, if that makes sense. And then for the second one, we kind of leaned toward 1, 3, and 6. We kind of mutually agreed on all of them. We felt like they all worked together. So, but the contact base, a lot of motivational interviewing kind of connects back to the research. And then we also felt that creating formal partnerships between MAT or harm reduction providers and other facilities agencies. So just regular meetings, planning and maintaining treatment plans, making sure everything is working together for the client. And then one thing that we agreed on the dislike interventions was, right about there. So back to 8 through 11, we didn't really choose a specific one. We kind of felt like all of them worked together just for the simple fact that they were low evidence, and with a lot of low evidence-based practices, we're going to find that, for one, not many people really did research on it, so we can't really say much about it. But we also felt that a lot of med schools have zero understandings for substance abuse. Number 10, we also disagreed, saying that a lot of facilities should focus more on their area, whether it's rural or whatever substance abuse is struggling, rather than just a specific waiver. So I feel like that depends more on where you're at. And then we thought on other interventions that might work is just for the providers to be more aware, for providers to require more contact-based education or training, to work with other agencies, or to just be a part of the community rather than the stigma-based, rather than a wording. And then some intervention barriers. We talked about the 12-step process, money, and older generations, to where a lot of older generations think, oh, well, if they have a problem, they should just keep their mouth shut and fix it in their own household, where nowadays it's okay to say, hey, I have an addiction and I really need help, and get treatment. And then for the strategies for overcoming, we just talked about the awareness and then the advocate to treatment. And we feel like the community should be more aware of the stigma and harm reduction in the community overall, rather than just one treatment. And I think that's it. If anyone else in my group 1 needs to jump in and say something.
Great, thank you, Stevie. I think we have time for one more group. Is there one more who would like to share before we open it up to have a more general discussion about the stigma stuff we've gone over today? Anyone else want to share?
This is Delia with group 16.
Great.
I don't have my Google Doc filled out either. I'm not that good with Google Docs. So I wrote it down. So ours was interventions that could reduce substance use stigma. So our most liked interventions are education and training interventions done in person, because we're having a lot of people check out, like providers and members that are wanting in person, or else they're not going to participate. And also creating partnerships amongst like treatment teams, and knowing the providers that are doing substance use treatment, so we can get access a little faster. The most feasible interventions were creating more slots for for MAT providers upon discharge to increase those visit times for patients for substance use disorders, and increasing awareness of the providers in treatment. And our disliked interventions were online trainings and treatment. And also we ran into a cultural component, which are kind of like the Native American population being kind of punished, or I don't know, it's being frowned upon for them to go out of the reservation for treatment. So that kind of went in with also interventions that might work, like for going out to get their treatment. That way, it was kind of a two-sided thing, because they go out that way. Not everyone knows their business, so that might work for them to leave the reservation. And barriers, the same cultural biases. We also brought up like different drugs bring different cultures, and I guess there's different drugs being more popular in different parts of the state. Access to Narcan was a big barrier. And then also providers feeling like Narcan is enabling our members. And then strategies for overcoming, it was just education and more trainings and access to Narcan.
Great, thank you so much. Is there anyone else from Delia's group who wants to add to what she said?
Yeah, hi, this is Eric Lemke. A big part of the cultural part of it was I was blessed to go down to Lincoln County because we're expanding our virtual peer support model to the regional hospital there. And we were able to meet with one of the ladies on the health council from the Mescalero tribe. And I asked her straight out, what kind of barriers do people have about getting treatment on the reservation? And she said that they would much rather go to Albuquerque or somewhere else to get treatment, because if they go into treatment, they are often ostracized or almost socially punished for having a substance use disorder. And they can go somewhere else and get the treatment, and not everybody's, in their business. Another thing is Lincoln County is really struggling right now with alcohol and meth. But here in Bernalillo County, I'm getting pounded with fentanyl. And those are two totally different cultures, especially with the opiate and the heroin culture. That's generational very often. So you have aunts, uncles, parents that do it, kids see it, and then grandchildren start seeing it and start using it. And that's often a cultural piece that I think is missed when addressing these kind of issues, because it's mostly based on location and race, it seems like to me. But the drugs each create their own cultures, and we have to adapt our treatment plans, our education plans around those cultures. And when we've been able to do that through face-to-face meetings like we had with Lincoln County Medical Center, where we actually did mock engagements and included the 3 most powerful people at that hospital, and they got to see us engage with patients, in the ICU and the ED. It kind of turned around their view of it. And I got a chance to talk to some nurses in the ICU and tell them a story about what it was like to be an addict in the ER or in the emergency department. And they apologized because they were part of that stigma. And the way they started the conversations out with us, you could tell. But we were able to bring a little bit of a glimpse on how hurtful and detrimental that might be, and reinforce the fact that addicts like myself do not go to the emergency room because we're having a good day. We often don't go seek medical attention, even when we desperately need it, because of the way we've been treated in the past. And unfortunately, it's going to be a lot longer person to person. But I think that's the most effective way. And unfortunately, the best way to reach the masses is through video trainings and stuff like that, which people tune out. Maybe if the government decided that if you are a provider an authorized provider, you have to be X-waivered. It would give those physicians and clinical staff an opportunity to actually work with somebody like me and realize if you gave somebody like me a little bit of compassion, a little bit of love, we would probably become your favorite patients because we're not used to it. And we are so grateful when we have that opportunity. So great job, Delia. I just wanted to pipe in a little bit and expand on it a little bit more.
Thank you so much, Eric. And were you saying that you work for a peer support group who works with the hospital?
I work for Presbyterian on the Peer Opioid Project, and we put peers in hospitals to work in the emergency department and the NICU downtown. We're expanding to the regionals to do a virtual peer support 24/7, 365. We're part of the onboarding process with new clinical staff. They hear our story before they even go out on the floor downtown. And this has all happened in less than 2 years. That's how hungry I think the healthcare community is for change, because they know there's a problem. They want to fix the problem, but they don't know how to fix the problem. And so far, this has been a very effective way of helping with that. And it's been the most amazing part of my journey yet.
Great. Yeah, it sounds like Presbyterian, which is wonderful to hear, right, is using multiple evidence-based interventions that we covered today, right? So they're doing a contact-based intervention by having you, a person with lived experience, talk to clinical teams and leaders. They're doing, having peer support as a part of a clinical team that's integrated into the hospital. And you also mentioned like spend time with people, which is kind of like intervention number 11, increasing the visit time. So it sounds like all of that's working out for you, which is amazing.
Yeah, it's definitely an approach taking in many different paths. And that's been born out of necessity. The nursing staff at the ED downtown will call me for the patients that are being difficult and don't want to get their labs drawn, because I'm able to advocate for the nursing staff and the clinical staff as much as I am for the patient. And I act as a bridge. If you get your labs drawn and you get these things done, your 18-hour ED visit's going to be 6. They want to make you stable because they care about you, and they can't do that until you give them this information. So you're dragging out the process. Maybe it's because you felt like you were disrespected in the past, but that doesn't have to be the case today. You can have an honest conversation with your doctor and say, this is what's going on. And he can actually come up with a treatment plan that might work because you're being honest.
Yeah, thank you so much for sharing that. And it's wonderful to hear that programming is happening. It's, with a little bit of evidence we have, y'all are doing so much of the interventions that we think might work or we know works. That's incredible. I want to open it up. So I'm not going to necessarily ask for any more groups to share, though if anyone would like to share their group, they can, but just open it up for more general conversation around these issues of stigma, especially with our healthcare providers, social service providers. How do we address this stigma? What are some of the other ideas you've discussed? What are some of the issues you've thought about during this training? So just opening it up for general discussion for anyone who wants to add.
I'll go. So in our group, we were talking a little bit about, and I think it kind of builds off of what we were just talking about, was that a lot of times it seems like providers get caught up in their needs, which is totally understandable. Everybody's worried about their own needs, but providers are worried about what they need from the individual that they're working with, where perhaps we need to focus more on the needs of the individual that are causing their behaviors, and rather than focusing on the surface, which is the problem that is creating a barrier for us as providers, we need to focus on needs of the individuals. And we also talked a lot about how early education and education of those people at that mid-level stigma, the people that immediately surround the individuals struggling educating them as well about what substance use disorder looks like, how triggers can be prevented or dealt with, or just Abe was talking to our group a little bit about how they provided a Narcan training to like elementary age students. And actually one of the students was able to then provide Narcan to his father and to her father and save his life. And that raising awareness in that way can be very effective. And as long as we're being careful about how we're raising awareness, we can do so without making the stigma worse.
My name is Tanya. I'm here in Lee County, a care coordinator, but I moved here from Southwest Pennsylvania, part of the heroin triangle between Columbus and West Virginia. Off of, I'm not going to try to pronounce Ms. Hill's first name, so I'm just going to call her by her last name. They taught my daughter in 6th grade how to administer Narcan because middle school kids were overdosing in the bathroom. So it was something they taught, and she knows to this day. The heroin triangle up there is something to where we were losing about, and it's a county about the size of Lee County, well, not big, but population wise. And you would have 20 to 30 people dying of heroin every day, especially when the carfentanil came into play. I think the state, the flat, pickle juice, the script for the Narcan to where anybody can go get the Narcan was a very good way to help with personalizing it for many people. And I know in that area up there, especially in the more affluent areas, you know, they didn't believe they had a drug problem in their community until one of their children died. But part of my job up there just shows you, someone mentioned in the chat that addiction doesn't discriminate. My job one day, I put an addiction psychiatrist into rehab. So it doesn't discriminate, and it is going younger. And I think education and getting everybody at the table and discussing within the community how each department, police, social agencies, schools can help at a younger age to build the relationship to avoid the stigma.
Yeah, and I like that you brought up not just, healthcare providers, but first responders, right? Schools as also being places where stigma might occur, and that we need to address that stigma to do things like, right, have effective trainings for harm reduction, Narcan trainings, et cetera. That's a really important point. Thank you. Eric, did you want to add?
I just wanted to say that my 3-year-old knows where my Narcan is upstairs and downstairs because I am on a pain management contract, and he knows how to administer it.
Yeah, that's great. There's not a lot of evaluation of those programs for kids, but it's great to hear that it seems like they're working. I would be excited to see the studies that also look at, showing us that that really is the case. I think it's probably true that kids can do this, right? Any other reactions to some of the stigma interventions that we went over, the educational trainings, interprofessional collaboration, government or organizational policies? By organizational policies, we mean things like clinic policies, agency policies, so not necessarily law. Did anyone else have any feedback on any of those? Why they would work, not work, what you like about them? Does anyone see any that they're thinking that they might implement in their organization going forward?
I think a lot of the stuff that you discussed in here and that everybody else has discussed does help in our jobs, or helps in my job, because I do peer support as well. And we're always looking for resources and, other people that are in the community that can help our members and stuff like that. So I really do think this was a really good class as well.
On the one you were talking about, the organization just having interventions, we were taught, I cannot remember her name, I think it's Jessica or Jennifer, was talking about she lived at the worked at the fire department, and they were trying to get the harm reduction out. So like, of course we can't stop someone from using, but a safe way of using it, and being able to have Narcan, give it, without question and things like that. I thought that was something that I really liked. And she also talked about the LEAD program. I think I said it right, LEAD, where instead of, someone getting in trouble out there and, being searched and being caught with drugs, getting arrested for the drugs, but saying, how can we help this person? And knowing that they're using and not selling drugs, things like that. And figuring out a different way to go about that rather than putting them in jail, having them get out of jail and then go back to using. How can we help this person to get on a different?
What we're doing here in Doña County is drug court through the magistrate court, where you go to classes, you meet with counselors, they will hook you up with doctors as well. They're there to meet your every need. You got the judge on your side. You've got all your therapists on your side that they will set up for you. And just to hold you accountable to get through the program in lieu of going to jail. And it does have a good success rate.
Real quick, this is Dennis Lopez again. We've had drug court, I think it was through Judge Knowles. We were the first pilot project, Judicial District 9 here in Roosevelt, and it's been very, very successful. So it's nice to hear that it's in Doña County now.
Yeah.
Great, so we've run out of time. Anne Marie put in the chat the completion certificate. If anyone else wants to add to the chat their contact information or say something about their organization, please do so. We were so excited about the turnout today. If there's any remaining questions or feedback that you all want to give us, you can email me. I'm putting my email in the chat right now. We are very grateful for all of your feedback. Again, like I said, this is a really new area of research. We don't totally know how to address substance use stigma, but your ideas, people working in the field, are really important for us thinking about what's feasible, what would work, what's not going to work. So this is sort of first steps. I wish I had more answers for you all than we have. Like I said, research is behind what people who are actually doing this work know. So we're trying to catch up. So thank you again for coming. Mindy, do you have anything to add before we go?
I was just telling everybody, thank you. I put my email in there and I was just saying, thank you so much for coming and thanks for letting us come present even.
Thank you.
Thanks for chatting with us today, friends.
Thanks a lot.
And then you guys are going to send the PowerPoint, right?
We will send the PowerPoint out and we will also attach the certificate of attendance again for those who might have missed grabbing it in the chat. And you can always reply back to us if you need anything else.
Awesome. Thank you.
Thank you.
You guys are awesome. I just want
Thank
you
you,
guys to know
everyone.
that I came to you guys as harm reduction and it's just awesome. Thank you guys for being here.
Thank you.
Yeah, that was a good one too.
Thanks for all the work you guys do down there. You pave the way for the work I get to do here. So thank you. It's because you guys are so advanced, literally, that I even get to do the programs I do here. Seriously, because of the work you guys do in New Mexico. So thank you. You're saving